Evening, all the aspirants present here. Today's topic is respiratory medicine, and the faculty that we have here is Dr. Vinod Jaiswal, sir. He is a consultant, critical care, Medicare at Royal Specialty Hospital, Dubai. Yes, sir, you may continue. Thank you.
Hi, good evening, everyone. Happy New Year to all. I hope you are studying well, and this year, whatever you part one, part two you want to take, hope you all will be successful. Okay, and whatever part I can play small, I'll be happy. So I think actually this is the fifth lecture. So it's a similar pattern actually, but this time topics are mixed. Before this, I was taking topic wise, but I think most of the important topics are covered. So I thought let's keep a mix of topics and see how it goes. Okay. Better you guys also answer. So, which one of the following is a contraindication to surgical resection in lung cancer?
हैं? कर लो कटो यार तो दो भाई कितनी देर में ला देगा हेलो
Hello, shall I continue? Yeah. So, any guesses? It's a tricky question. Let's look at the answer. The answer is A. Actually, is a vocal cord paralysis. Why it is so? The vocal cord involvement means that the recurrent laryngeal nerve is involved. Means the disease is already locally advanced, and this represents a T4 stage of the TNM staging, indicating that there's a direct invasion of the mediastinal structure. So surgical resection is not possible at this stage. What are the other options we had? Sorry. FEV1 less than 1.9. Actually, pre-op when you evaluate, so FEV1 more than 1 point, predictable more than 1.5 predict that the operation may be successful and patient will not require a respiratory support. Okay. So the predicted post-op FEV1 more than 40% is considered acceptable for surgery. Squamous cell is one of the non-small cell carcinoma. If detected early, yes, it is an indication of surgery. Okay, and the remaining are very obvious. Calcium and hemoptysis. Calcium is because of the paraneoplastic syndrome, and hemoptysis may be local bleeding. These are not a contraindication for surgical lung resection. Actually, we have done the CA lung, but just I included this question, which was I thought is interesting. All right, let's move. A 40-year-old obese woman presented to her GP complaining of daytime somnolence. She is asked to fill out an Epworth Sleepiness Scale questionnaire and scores 20 out of 24. Her GP arranges overnight pulse oximetry and she is diagnosed with obstructive sleep apnea. Alongside weight loss, what other intervention is appropriate in this setting?
CPAP B.
CPAP B. Why not BiPAP?
For airway to remain patent, you require continuous positive airway pressure. It is not a Y-level positive airway pressure, which is required in COPD and in carbon dioxide retention.
Right. So, yeah, so it's a severe obstructive sleep apnea because the score is 20. There are other scoring systems also which I will going to tell. So answer is correct. Overnight CPAP with continuous positive airway pressure ventilation. Let's look at the other options also. So yes, the IFAS score is high, and the SIGN guidelines, sign guidelines recommend that any sleep apnea has to be weight reduction first, and then overnight CPAP, or even the daytime also. BiPAP not routinely, but it can be used if some type 1, type 2 respiratory failure along with is present, can be considered. Other options like mandibular advancement should only be used who cannot tolerate CPAP and which have mild symptoms. And the surgery, generally, randomized control trial has shown that evulo-palatopharyngoplasty is not effective. So yes, CPAP, weight reduction, and CPAP is the most standard treatment for moderate to severe OSA. We'll do a little bit uh, study on the OSA. I think we don't need to go into detail what are the signs and symptoms of OSA. Everybody knows, associated with obesity, many other factors, sleepiness, somnolence in the day, napping time during the day, and loss of energy. So there are. This is one of the questionnaire, but there are many other questionnaires people are using in the clinics. So this is one of the questionnaire which you can ask, and accordingly scores are given. There are calculators available which gives you the score. Okay, so do you feel sleepy during the day? Daytime sleepiness is a problem. Is it difficult to keep your eyes open at the daytime? Do you struggle to stay awake during the day? Do you take naps? How often and how long do you nap? Do you fall asleep at times when you don't want to, like watching movie, reading a book? Very common questions. These questions about sleepiness. Other questions about tiredness, fatigue, and low energy. Do you lack energy to go about your daily activities? Do you tire easily, sooner than others? Do you feel physically, mentally exhausted? And the questions differentiates sleepiness from related complaints. Okay. So does your problem bother you more if you sit to read for an hour or you go out shopping for an hour? Which of the following is the single most problem for you? Sleepiness, tiredness, fatigue, or lack of energy? Anyway, these questions, as for the exam, is not important, but you should know what are the questions, and in practice, you can come along such patients, so you can pull out this list and try to get a score and then see. There's another questionnaire. There's a stop bank questionnaire, which is more commonly used. There's another one is there, enhanced stop bank questionnaire, but this is commonly used and scoring is easy. So you can see that low risk, intermediate risk, and high risk of OSA. Okay, questions are similarly actually if you see, but some different. Snoring, tiredness, has an observed stop breathing, choking, gasping, pressure means in high blood pressure, body mass more than 35, age more than 50, neck size, measure around Adam's apples. Is your shirt collar 6 inches larger? Or gender, males. Okay, more common in males. So low risk is 0 to 2, high, intermediate or moderate 3 to 4, and high risk is 5 to 8 questions. This is a more definitive diagnosis, which when you screen with the clinical questions, whether the patient needs a home assessment or at clinic assessment, polysomnography you do. Okay. There are three indexes, AHI, which is apnea hypopnea index, RDI, which is respiratory disturbance index, and REI, which is respiratory event index. Okay. So when you do polysomnography, if AHI 5 to 14 per hour sleep plus one or more sleep associated conditions, or more than 15 per hour sleep when AHI is there. RDI 5 to 14 again similar. And when you do home sleep apnea or home testing, when the REI, respiratory disturbance, respiratory event index more than 15 per hour during total recording time. So these are the diagnostic criteria for OSA. Okay. So there are criteria also which patient you should test at home, which patient you should test at clinic, So, but I don't will not go into details, may not be that relevant, but yes, it's important in a daily practice, not maybe for the MRCP. So you can remember roughly this, roughly more than 15 AHI or RDI in polysomnography or home sleep testing should rule in favor of OSA. Okay. Treatment, moderate to severe, which was our patient. So positive airway pressure therapy with CPAP. Again, the recommendation is not that great, but still grade 2C is good enough. Mild OSA, suggest CPAP in certain patients. like patient who perform mission critical work, example, airline pilot, symptomatic patients with excessive daytime sleepiness, non-restorative sleep, patient with comorbidities such as hypertension. So mild OSA with selected conditions, you should see PAP along with other measures, weight reduction, healthy lifestyle, and sleep hygiene routine, all supportive measures. Okay. Any questions on OSA? Anything you want to ask? Okay. A chest X-ray of a patient with sarcoidosis shows bilateral hilar lymphadenopathy but otherwise normal. What chest X-ray stage does this correspond to? Stage 0, stage 1, stage 2, stage 3, stage 4.
Stage 1.
Stage 1. Okay, good. Yeah, just the bilateral hilar lymphadenopathy corresponds to stage 1. Okay. Stage 0 is normal. Stage 1 is bilateral hilar lymphadenopathy. Stage 2, bilateral hilar lymphadenopathy plus interstitial infiltrates. Stage 3, diffuse interstitial infiltrates only, and stage 4 is diffuse fibrosis. Of course, other investigations you can do to diagnose sarcoidosis. Few of them are, but mostly diagnosis is clinical, so and suggested by the radiological features. So spirometry may show a restrictive defect. Tissue biopsy may show non-caseating granuloma. Sometimes this is the only abnormality you can find along with some symptoms. Gallium scan, but not routinely used nowadays. The QM test, which is they take the sample from the affected patient of the sarcoidosis from the kidney and they do subcutaneous test. But again, no longer is recommended due to concerns about cross infection. So yes, the staging is important. May ask in the MRCP exam, and how you diagnose, depending on what you should know how we can diagnose, or depending on the question and scenario you can answer. So spirometry, tissue biopsy, gallium scan. Okay, or there are some clinical features and associated findings or syndromes you can diagnose sarcoidosis. Okay, so there are two columns if you see: highly probable and probable. Okay, uh, if you go in history, Lofgren syndrome, the questions can come on Lofgren syndrome also. It's an acute condition actually, and it's a bilateral hilar lymphadenopathy associated with erythema nodosum and arthritis or periarticular inflammation. So if this is present, it's classical and high probability of sarcoidosis is there. Okay, in the history, if you find another features like seventh cranial nerve involvement, renal AKI, or atrioventricular nodal block, cardiomyopathy, okay, um, and spontaneous or inducible VT because of cardiac involvement with no other risk factors. So high probable of sarcoidosis on the history. And physical example, if you find lupus pernio, which are some um, radiculopular lesions around the nose, or uveitis, or optic neuritis, or erythema nodosum. Again, these are also disease defining or sarcoidosis defining kind of physical findings. Okay, but again, if this classical is not present, other lesions like maculopapular erythematous or violaceous rash, subcutaneous nodules, quite common, scleritis, retinitis, lacrimal gland swelling, granulomas, parotid enlargement, hepatomegaly, splenomegaly, again, along with clinical features, can be diagnostic, a probable diagnostic of sarcoidosis. Imaging, as per the we have seen already with the X-ray or with the CT also we can do. So bilateral hilar lymphadenopathy, you should highly suspect sarcoid. in perilymphatic nodules. This scanning PET scans with gadolinium. Okay, osteolysis, cystic punch out lesions, trabecular pattern in the radiograph, or parotid uptake in gallium scan or PET scan. These again are highly suggestive. Okay. Upper lobe fibrosis in CT or PET, peribronchial coughing, extrathoracic nodes, increased inflammatory activity in heart, enlargement of nodules in liver, spleen, bone. So these are also probable on the imaging, but more commonly on the lungs. Another suggestive are hypercalcemia or hypercalciuria with abnormal vitamin D metabolism. Okay. If you go other testing in probable, so reduced ejection fraction, okay, with no risk factor causing restrictive cardiomyopathy, elevated AS levels, we commonly do it, but it's, if you see it is in not highly suggestive, but it's um, supportive only probable and should be more than 50% above the normal. Okay, nephrolithiasis because of high calcium, bronchial oral lavage you can do and see elevated ratio of CD4 to CD8, alkaline phosphatase greater than 3 times the upper normal limit, or new onset EV blocks in middle young age patients. Okay. So these are the probable, highly probable and probable diagnostic criteria in support of sarcoidosis. Okay. I think I should not have any doubt about answering any questions if comes. Okay. Treatment generally there are three. Sarcoidosis treatment can be divided into three. I did not made a slide as per that, but it's asymptomatic, mild to moderate, and severe. Okay. In any of these, whether it is asymptomatic, whether it is mild to moderate or moderate to severe, but in any of this, if it is rapidly progressing radiological or clinical features, then you go with steroid and methotrexate combined together. Okay. So in general, when any type of sarcoidosis but it is rapidly progressing, so you go with steroid as well as methotrexate and then assess the response after 4 to 6 weeks. If we talk about asymptomatic patients, so there are some criteria where you can use steroids, which if the patient have these three criteria: stage 4 radiologic disease, but patient is not symptomatic, moderate to severely reduced vital capacity or diffusing capacity, or exertional hypoxemia. These are asymptomatic patient with this kind of criteria. Then you can start with steroid, and if it is rapidly progressing, then you add methotrexate. Again, mild to moderate, you start with only steroid, and if it is rapidly progressing, you add methotrexate. And in severe, if it is not rapidly progressive and it is chronic, you may just start methotrexate and then add plus minus steroids. Okay. Let's move. Next question. Which one of the following is least associated with Carter-Jenner syndrome? Males of fertility, dextrocardia, recurrent sinusitis, bronchiectasis, and malabsorption.
Male subfertility.
Males of fertility. Okay. Why not any other?
Maybe malabsorption because dextrocardia, sinusitis, and bronchiectasis are part of this.
Correct. Those three are the cardinal features. So remain with the two, males of fertility and malabsorption. The answer is E. Okay. So it is called as primary ciliary dyskinesia. It's a rare genetic disorder with situs inversus totalis, including dextrocardia. So chronic sinusitis and bronchiectasis are common. So defects in the structure and function of cilia lining the respiratory tract, leading to impaired mucociliary clearance. This is the pathophysiology. So generally malabsorption doesn't happen in this, but yes, male subfertility it affects the motility of the sperms and can cause fertility issues in males. But malabsorption in general, not due to primary Carter-Jenner syndrome.